Hey guys, Chris here from Lifeline EMS Training. Today we're going to chat about bleeding control 101, so the down and dirty. A lot of people try and complicate simplicity when it comes to bleeding control. We want to simplify it because while at the end of the day, all bleeding stops at the end, we don't want to get to that point. We want to keep people's blood circulating in them so they stay alive. So, got blood. So, how much we got? On average, we have about 12 pints, 6 liters of blood circulating our system. A loss of 2 or more pints, so greater than a liter, can lead to shock. Just as an FYI, a blood donation is around 500 milliliters or half a liter. So, look at this picture over here. It's kind of showing you how much blood volume liters you can lose in the different locations. So, in your arm, about 1 liter, upper thorax, 3 liters, abdomen, 3 liters, lower pelvis, 3 liters, femur, 2 liters, distal leg, proximal and distal, a liter each. So you can lose a decent amount of blood with internal hemorrhage in your thorax, abdomen, pelvis, and upper thigh. That can be quite significant, symptomatic, and problematic. So we get regularly, what's the different classifications of blood loss? Well, so the American College of Surgeons had a chart that they put out, and this is a modified version, so it takes a couple of the pieces out of it. But there's 4 different classes. So here on the left, you see the 4 classes, 1, 2, 3, 4, and what the treatment is. So see, like 1 and 2 is just isotonic crystalloid to replenish. 3 and 4 are both fluid replenishment and blood replenishment, because the person's lost so much blood in these instances. We definitely need to maximize that oxygen carrying capacity, electrolytes, and clotting factors that come with it. So class 1, it's up to 750 milliliter blood loss, about 15% of the body's blood volume. Heart rate's less than 100. But there's an asterisk there. And if you go down the bottom right, you see that beta blockers impact this response. So beta blockers blunt the sympathetic response and influence on the heart's rate. So it blunts the heart's ability to upregulate or increase its beats per minute with epinephrine influence. So when a person is trying to sympathetically compensate, beta blockers blunt that. So back to class 1, respiratory rate between 14 and 20. So climbing, getting to the upper end of normal. And remember, as always, when you breathe in, you create negative pressure in your thorax and help draw blood back to your heart. So part of this, as you go down here with the increased respiratory rates, is that trying to help draw more blood back to the core and to the right heart. So still with class 1, no change in systolic pressure. Urine output's about 30 plus milliliters an hour, and mentation is slightly anxious. So class 2, slow replenishment with isotonic crystalloid, 751 to 1500 milliliters, about 15 to 30% body's total volume, 100 to 120 on heartbeat. Again, beta blockers can affect that. And now the respiratory rate's going up, right? So we're trying to get that drawback, that suck blood back up into the thorax with that negative pressure at a rate of 20 to 30. No change yet to the systolic, because this is still in that kind of compensated shock state where they're maintaining their pressure, but you're seeing the upregulation of the other factors. And then after 2, we start to go into the unable to maintain that compensation. 20 to 30 cc's an hour for urine output, and mildly anxious. So that adrenaline, the body's fight or flight response is really starting to show itself now. Class 3, isotonic crystalloid, blood replenishment, 1501 to 2000 milliliters, about 31 to 40% body's total volume. 120 to 140, that's really high. That's high RPM right there for the cardiac output, heart rate times stroke volume. Your volume's so low that the contractility and heart rate are the only thing keeping you rolling, so your heart rate's out the roof. Respiratory rate 30 to 40, really trying to suck that blood, vacuum suck it up into the thorax. Systolic starting to go down, 5 to 15 cc's per hour of urine output. So your body, your kidneys are really showing that retention, not allowing the fluid out, because they're trying to maximize the amount of volume that's circulating through your body. Anxious and confused. So we're starting to see the frontal cortex is reduced perfusion. So we're starting to see confusion, cognitive changes. So this person's body is really in a stress response and compensatory state where it's starting to deprioritize certain areas, and it's starting to impact perfusion to key areas like the brain. Class 4, so isotonic crystalloid, blood replenishment greater than 2,000 milliliters. That's greater than 40% of the body's total circulatory volume. Heart rate's above 140. That's cranking along. That's really fast. You're getting to the point where above 150, cardiac output becomes affected by the rate because the chambers don't have enough time to fill in the heart. So we're really at that kind of teeter point where they're going to crash quick. 35 plus respirations a minute, really trying to suck blood back up into the thorax there. Systolic's going down. Urine output is minimal to none, and they're confused or lethargic. Their brain is really not getting good oxygenated blood flow. So that's a quick blood loss classification chart, and it really kind of helps us with the severity to the compensation or decompensation state that the patient's in, and how hard their body and how much of their body's being recruited to compensate for that loss of volume. So types of bleeding, we have superficial, scratch, scrape. We have venous, which is that slow, steady, darker red bleeding. And we have arterial, which is pulsatile or steady pumping bleeding. Nothing changes. The initial steps when that person's bleeding is apply direct pressure, elevate the extremity, and then apply pressure to the nearby artery or the artery that's feeding it. Keep it simple. So when we talk about bleeding control, there's really three things we want to focus on. This is really kind of tied to that wound packing or when we're trying to establish that clotting. It's PVT, pressure, volume, time. So we want to put so much volume in the area we're wound packing that volume, 10 pounds in a 5-pound bag, emits pressure on the walls. So we create stasis and allow the clot formation to occur. You don't want steady flowing into the wound cavity. You want to create so much pressure inside that it's put so much volume inside that it's emitting pressure on the walls and inhibiting that. So volume, again, 10 pounds in a 5-pound bag. You want it to take up space, less blood loss, more pressure. So volume helps with pressure as well. And then time takes about 3 minutes to form a clot and it trigger that intrinsic clotting cascade. So maintaining that pressure of what you've packed in for 3 minutes. So let's talk about non-compressible areas, the box of life. So we have two boxes. I like to think of them two boxes. I get some people that want to argue with me that they don't see it the same way, and that's perfectly fine. But we have the top box, the bottom box, thorax, abdomen, and really it's the diaphragm that separates them. And so with these boxes of life, they have their own kind of idiosyncrasies. The top box has to have that range of the diaphragm so the diaphragm can go down, make the container bigger, make that negative pressure, allow the lungs to expand, draw atmospheric air in for breathing, exhale carbon dioxide, and oh, by the way, during that negative state, draw blood back up. The abdomen doesn't need those pressure requirements. And in fact, the organs that create motion during the digestive process have their own muscles that create that peristaltic, and I can never say that word very well, or that rhythmic motion of movement through their cavity. So you take that box of life, and if we have a hole that goes into them, that's a problem. Well, we can't pack it because it would just be an endless box where we would be putting stuff in and organs would be slightly moving over as we continue to push through. But what we like to do is reestablish the wall of the box. So when there's a penetration or damage to the wall, things we want to do: reseal the wall, establish that structure, establish that allowance of those pressure changes or the preservation of the wall integrity. So put your gloved hand over top of it. If it's the thorax, you want to put a chest seal on it, and you want the vented one on the side up. You want the vented one on the side up because if you're laying the person on their back, think about a level, the air is going to go up and out the vent.
Chest wound management. Anytime the box of life up here has a hole in it, first thing we want to do, seal the hole, right? We want to maintain that negative pressure as best we can, that negative pressure in the thorax. We don't want it to equalize with the environment because that inhibits blood return from the vena cava and also the ability of the lungs to expand with the diaphragm, allowing extra air to come in or external air to come into the mouth. So it's that negative pressure maintenance is really what we're doing when we're talking about chest seal management on the thorax. As a reminder, anytime there's one hole, there's two holes. Always roll your patient over, look under the armpits, front, back, do a good assessment. Chest trauma, one of the ones you want to make trauma naked on the scene because you want to find any of those holes, whether it's under the pit, whether it's under the scapula, because what went in here or went in there could have bounced off, ricocheted around. So this is the SAM chest seal. This is probably by far the most durable and most sticky chest seal we found. Same thing, peel away, put one side down, and as you peel away like your car sticker, this one has a little pop because it's got a little rigid point right here. And so this is actually very durable seal or vent. So these are very durable. I love the surface area on here for the hot, sweaty summer nights. But that's a SAM chest seal. Again, you would just roll the person over, put the other one on the back.
So breathing mechanics, it's the only time it's really good to be so negative. Resting state is what we see here on the left, smaller lung cavity, diaphragm's up, diaphragm goes down, create negative pressure because the container gets bigger. So that brings the air in from the atmosphere, but it also brings the blood back up the vena cava. And that's why when we're doing chest seals, it's so important. We're not like plugging the hole. We're trying to maintain that wall integrity so that we can maintain as best negative pressure as we can for the normal respiratory cycle and venous return to the heart. You get that hole into that thorax, again, cover it up, chest seal time. So going back to those compressible areas, those are areas you can tourniquet or wound pack. You can compress them. So the inguinal areas here in the pits, the nape of the neck, the extremities themselves. So you can take a tourniquet and put them on any of the extremities that allow circumferential compression. Wound packing, 10 pounds in a 5-pound bag. You're trying to pack the volume into that cavity so it emits that outward force so that it creates stasis, occlusion, and allows the clot formation.
So our wound starts bleeding now, and if we know where the pressure point is, or the artery that's feeding it is, let's go there. Now you're gonna find a bunch of people that'll give you 52 different methods of doing or taking the gauze out. They want you to get a pen or a pencil, poke the center hole out so it stays nicely in your hand. If you notice, the key, put downward pressure and just start packing. In this instance, I'm using my thumb to unravel the gauze. I'll show you a different method here in a second, how you can actually now start to introduce both of your thumbs into the equation. Because what you're trying to do is just pack every inch of that wound site. What we're looking for is the walls of that wound to start swelling. So we want them to start swelling. And if you'll see, the bleeding is slowing down because I'm really pushing on the wall here. Grab my other gauze out. And I'm to the point where I can't really get any more in there. That's what we're looking for. Take the rest and you push down for 3 minutes. Now, if we were in a TCCC situation or where some position I had to have my head on a swivel, combat, hot zone, whatever, you can take your knee and put this down. You can put your knee down anyway. Most people don't like to do that. But put your knee down, you need downward force for 3 minutes. If you have an IT clamp, you can take the IT clamp and clamp over top, and then you don't have to worry about this. They're not super cheap, but you can take a compression dressing, wrap it around. But if you're in an area that's not circumferential, like the inguinal area, then you're just at the mercy of that downward pressure. And this is where everybody usually cuts corners, but this is as important as packing it. This is what triggers or allows for that clotting cascade to go into effect. So back to these hemostatic agents. Work or help really well with patients who are hypothermic, patients who are on blood thinners. These are also great for you get a person who has a laceration, you can cut a little piece off and put it over top of the laceration and wrap it up. So they really are good to have, but if you don't, you're not dead in the water, no pun intended. So we're about halfway there. If you notice, my downward force is my arm is pushing down on the site. I'm not cupping over top of it. I'm not caressing the wound. It's downward force. Again, I want to add more pressure to the walls of that wound to help stop blood flow, create stasis so that those clots can form. Also remember, this isn't a sterile procedure, so if your gauze falls on the ground, pick it up and just pack it back in. It's going to be cleared out when they get to the trauma bay. And also in real life, the patient would probably be screaming right now because you just packed a bunch of volume into their wound. My experience, they are not happy with wound packing. They'll complain about it, they'll yell at you, their airway's clear, they have good circulation to their brain. Those are all easy wins through assessment, but it is quite painful, like tourniquets.
When we're talking about hemorrhage control and trauma patients, the triad of death is acidosis, coagulopathy, and hypothermia. So we don't want them shivering. So if they increase their metabolism when they start shivering, there's a potential they could become or anaerobic in their respiration and make lactic acidosis. And when there's already a decreased perfusion state from the loss of blood, they're much more vulnerable to that. We don't want them to become hypothermic and start to shiver. So we want to keep them warm. And for optimal clotting, we want good calcium levels and good temperature, because if they become hypothermic and acidotic, it inhibits the ability of the platelets and the red blood cells and the fibrin to function and actually help them clot. So this is a vicious cycle here, that if they become acidotic from hypoperfusion and hypothermic, their hypothermia can create shivering, but the hypothermia also affects coagulopathy. If they're not clotting well and they continue to lose blood, their cells that are tissues that aren't getting good oxygenated blood flow will go into an anaerobic cellular respiration state and make more acidosis. And it's just a loop of death, literally. So the thing I want you to take away with this is take the dollar foil blanket that is on every rig. It is easily purchased off of any Amazon, eBay site. We'll even put a link here in the show notes. Take that, keep one in your kit with you. Keep one in the glove box of your car with you. So if your car dies in a snowstorm, or even if it's just mildly cold outside, you have a blanket with you. If you're bored, take one of these blankets out with your crew and have everybody put it on for a couple minutes. People will start to sweat. These things are so underutilized and are so ridiculously cheap and so awesomely effective. They need to be used much more often. I challenge you to use them on every trauma patient you bring in, especially one that's on one of those backboards that inevitably is 20 degrees colder than its environment. Use these foil blankets. They are the bomb, and they help prevent the trauma triad of death. And if you're interested in a investment opportunity, we can take the old Snuggie and make a trauma Snuggie and then upmarket it with a medical grade price point, and we'll all be rich, right? So the Snuggie would be awesome if we made a trauma Snuggie. People remember that, and it's kind of catchy versus the foil blanket. But at the end of the day, keep your patients warm. Do not let your trauma patients get cold. We hope that helped keep it simple with hemorrhage control. As always, if you have any questions, you can hit us up at info@lifelineemstraining.com, and we hope you have a great day.